So I'm Dr. Kristen Lindgren. I am the owner and physician provider here at Lindgren Functional Medicine. I am originally trained in family practice, which I did for many years. About 5 years ago, I left that position and went back to school and did a fellowship in functional medicine, completed that, and did my board certification in functional and regenerative medicine, and have been doing mostly holistic care since that time. My staff loves this slide. You see, the benefit of doing the PowerPoint is you get to pick who's on it, so you see I'm not. So upper left is Ivy Lisa, my partner in crime. She's my nurse practitioner. She is also fellowship trained and board certified in functional and regenerative medicine. Lynn Casper, our fearless leader, manager. Megan Van Pay is our wellness and weight loss coach. Lucy and Laura are our two MAs, and Raya is our front desk representative and I guess resident expert on CBD products, right? We can all relate to this picture, can't we? So a communications major told me once that every good presentation starts with a story. And I don't have any interesting stories about me, so I'm going to start with a little story about you folks. Once upon a time, many, many years ago, your mother released a mature egg from her ovary midway through her cycle, something that happened about every 28 days. And then a sperm came along that was dressed a lot like your father and fertilized that egg. That fertilized egg was your very first stem cell. That fertilized egg then divided into a small cluster of cells that was then called an embryo. Up until that point in time, all of the cells that were the fertilized egg had the ability to become any type of cell in the body. And then as time went on, those cells began to differentiate or commit to being one particular cell or another, whether that was cells for your heart or your brain or your eyes. And that differentiation process continued for 9 months until all of your organ systems were fully formed. And those stem cells didn't just differentiate, they did something else that was really special, and that was they secreted signals and growth factors that stimulated growth and repair. And when you were cooked just the right amount, your mother gave birth to you. Even after you grew up into an adult, and then a much older adult, you continue to maintain stores of stem cells all throughout your body. But like you, your stem cells have continued to age, become less able to repair, and have ultimately driven you here tonight in an effort to learn how to restore them. By the end of this talk, you will have hope for a happy ending to the story at the end. How's that? Questions? So what is a stem cell? Well, on the outside, a stem cell, sorry Rob, looks just like any other kind of cell, but they're not. They're extremely special for 3 reasons. First is that they have the ability to differentiate or turn into other types of cells. The next is that they have the ability to divide indefinitely. Our regular cells live and divide only for so long until they die off, but stem cells are essentially immortal. The last thing is that they have the ability to fix and repair broken or damaged cells around them. So from a regenerative medicine standpoint, this is the characteristic of stem cells that is so exciting. So you can divide stem cells up into a whole bunch of different categories, but I think that the easiest way to think about them is being either embryonic stem cells or adult stem cells. Like I mentioned earlier, embryonic stem cells are those stem cells that exist at the very beginning of fetal development, just for those couple of days after an egg is fertilized. Although highly controversial, embryonic stem cells are cool because they have the ability to become absolutely any kind of cell. We call those totipotent or pluripotent stem cells. But despite all of their ethical challenges, they don't work for any clinical benefit in humans. Embryonic stem cells are actually too undifferentiated. When we put them in a petri dish and try to grow them, they become a tumor mass, typically something called a teratoma. Despite close to, I looked this up several times, it's $3 billion are spent on researching embryonic stem cells for human use. There's not ever been a successful clinical trial. So for clinical purposes, that leads us to the other category of stem cells called adult stem cells. Like I mentioned earlier, adults, even aged ones, continue to have stores of stem cells all throughout their bodies. Back in the 1950s, when scientists were first studying stem cells, they found two different kinds. The first was hematopoietic stem cells. These are the cells that turn into blood cells. When you hear people talk about a bone marrow transplant for something like leukemia, those are the cells that are replaced. The other type of cells that were found were called bone marrow stromal cells, or get ready, mesenchymal stem cells, or mesenchymal stem cells, depending on which part of the country you're from. From here on out, I'm going to refer to them as MSCs for short. They are cells that repair cartilage, fat, and connective tissue. Since then, researchers have found that MSCs are present throughout the entire body. They're typically found around blood vessels. They're hanging out, watching, waiting for something bad to happen, like disease or injury, and that activates them to get moving and send repair and regenerative signals. The richest source of these MSCs actually comes from umbilical cord tissue of all places. Even though a baby isn't an adult, umbilical cord tissue is considered to be of adult origin. MSCs from umbilical cord tissue they're essentially bald. They don't have any proteins or markers on their surfaces that trigger the immune system. So we call those kinds of cells immune privileged. So they just go unrecognized by the immune system. If you think about it, an umbilical cord is shared by two genetically distinct humans, right? A mother and a baby. So it would stand to reason that the tissue between the two of them would need to be, from an immunological standpoint, Switzerland, so to speak. So as it turns out, because those cells are immune privileged, we can put the MSCs of really any umbilical cord tissue into any adult human without the risk of rejection. And I'll come back to that later. In areas of disease or damage, MSCs secrete signals that do a couple of things. They control inflammation, modulate the immune system, and stimulate regeneration. When we look at the data on using MSCs to treat different conditions, they are extremely disparate. They don't seem to have anything in common, but those things they do. They are conditions that have some issue with inflammation, immune system dysfunction, or poor regeneration. We really need healthy MSCs as like repair or fix-it guys to undo the damage that we do to our bodies as we go through life. So here's a really depressing slide. When you were a baby, all the way over there on the left, that was the number of stem cells that you had in your bone marrow. By the time you reach skeletal maturity, next bar to the right, at age 11, 12, 13, 90% of your stem cells are gone. And that's pretty much what you have to live on until you completely run out. You thought the next slide would be uplifting, but it's not. On top of declining numbers of MSCs, we have declining function of MSCs. We always have wear and tear going on as we get older, and our ability to fix that wear and tear just sort of slows down the older we get. An easier way of putting that is the older you get, the faster we age. This slide shows you the doubling time of an MSC taken from a baby, a 35-year-old, and a 65-year-old. In a baby, they divide every 24 hours. In a 35-year-old, they divide every 48 hours. In a 65-year-old, they divide every 60 hours. That sounds pretty linear, right? The older you get, it's like the slower it takes to recover. If a 7-year-old falls and breaks his leg, he's back running around again in a couple of weeks, right? If an 85-year-old falls and breaks his leg, that healing time is exponentially longer, if he recovers at all, right? That decline in regenerative capacity actually isn't linear at all. It's very exponential. I'll put it another way. If you take an MSC from a baby and put it in a petri dish, it divides every 24 hours, and at the end of a month, you have 1 billion cells. If you take an MSC from a 35-year-old and put it in a petri dish, doubling every 48 hours, at the end of a month, you have 32,000 cells. If you take an MSC from a 65-year-old, at the end of one depressing month, you have only 200 cells. So as our degeneration starts to outweigh our regeneration, we're just going in one direction. It's not just about numbers, it's about function. Remember, not only do we have far fewer cells, but the ones that we have lack the same capacity for repair. Again, MSCs are found throughout the entire body. The areas of highest concentration are bone marrow, fat, or also called adipose tissue, and umbilical cord tissue. Bone marrow and adipose tissue are still used for sourcing cells, but require painful procedures to get it, like drilling through the pelvic bone to harvest bone marrow cells, in-office liposuction procedures, which, although attractive to some of my staff, is still very uncomfortable. Remember, we can harvest those cells, but again, the likelihood is that they're already more than 35 years old, so their ability to do their job has already declined significantly. Most of us did not think to save our own umbilical cords, but thankfully, high concentrations of MSC can be found in any umbilical cord. And remember that umbilical cord tissue is immune privileged, so we can safely put cord tissue from any healthy live birth into any aging adult human without the risk of rejection. Umbilical cord tissue is fast becoming the overwhelming favorite when it comes to stem cell therapies. These cells are multipotent, not pluripotent or totipotent like embryonic stem cells, so they don't want to become babies. There's no risk of tumor formation. In this process, the mother and baby are both highly screened and selected. The tissue is 100% free from blood cells. Umbilical cord tissue for regenerative medicine comes from healthy live cesarean births from here in the United States. It's tissue that's discarded otherwise, highly screened for infection and sterility. To date, there's been no reported cases of rejection after hundreds of thousands of procedures done here in the United States. Umbilical cord cells also migrate. They're like heat-seeking missiles. They're drawn to areas of damage and inflammation, and they go there to fix things. So they have positive effects far away from their original injection site. They also have greater plasticity or versatility than bone marrow or fat MSCs. They have longer telomeres or life expectancies and greater immune modulating properties. Remember the depressing doubling data? If you have a problem that requires 1 million stem cells to fix and you only have 32,000, you basically have a math problem, right? Adding in healthy young MSCs helps to fix that math problem. Those cells actually convince old cells to behave like young cells again. They secrete all of these cytokines and growth factors, molecules that promote regeneration, they modulate inflammation and optimize immune system function. MSCs don't turn into anything else once we put them into people, and I think that that's a common misconception. We can make that happen in a lab, but that doesn't happen in vivo. The cells work by secreting all of these factors. I think it's a little misleading to use the word stem cell therapy for that reason, because it implies that it's the cells themselves that are doing all the work, and it wouldn't be nearly as effective without the tissue around those cells and the signals that they secrete. The preferred nomenclature by the FDA is actually not stem cell therapy at all. It is human cell and tissue products. So if you're doing some research on this, you may see that terminology, HCTP, human cell and tissue product. I did not invite anyone from the FDA tonight. So stem cells, most people have heard of, so that's where we're using that tonight. This is a really busy graph with extremely small font. But anyway, the point is just to compare and contrast the stem cell tissue source from different areas of the body. Pharmaceuticals are all the way on the left, as you can probably see. Peripheral blood underneath the red, that is platelet-rich plasma typically. Placental tissue in the green, that's also called amnion. You may have heard that terminology. That's amniotic fluid, matrix, and membrane. Umbilical cord tissue there being umbilical cord blood and umbilical cord matrix. That's what we've been talking about, the MSCs from umbilical cord tissue, bone marrow in the gray, and then adipose in the yellow. And then over on the left, they list all of the growth factors, chemokines, cytokines, scaffolding, MSCs. If you take one thing only away from the slide, it's just which category has the most number of check marks. And it's the umbilical cord tissue. I resisted the urge to geek out, and I lost. So here we go. This just couple, so just bear with me here. There's a couple of landmark studies using umbilical cord MSCs, and this was one of them. It was published in 2013. Umbilical cord MSCs were used to treat patients with active rheumatoid arthritis. They took 172 patients, all of whom had inadequate responses to conventional therapy. So they were on disease-modifying drugs, but their symptoms were not well controlled at all. The patients were divided into two groups, those receiving conventional therapy plus a placebo, and those receiving conventional therapy plus IV umbilical cord MSCs. So they were given infusions twice. Participants were tested for markers assessing safety and levels of inflammation. No adverse effects were observed during or after the stem cell infusions. In the umbilical cord MSC group, patients had significant reductions in inflammatory markers, increases in markers of healthy immune system function, and complete remission of their RA symptoms according to the American College of Rheumatology criteria. Not one of those positive findings was noted in the control group, who continued to have active RA symptoms despite conventional therapy. This is just the graphs depicting those results. I won't bore you with this, but since 2013, this almost identical study has been repeated multiple times. This was a study published in the Journal of Endocrine in 2012, looking at the effects of MSCs on patients with type 1 diabetes. So type 1 diabetes is an autoimmune condition where a person's immune system makes autoantibodies that destroy the cells in their pancreas that make insulin. In this study, they evaluated 29 patients with new onset type 1 diabetes. They divided them into two groups. One was treated with umbilical cord MSCs, and the other was treated with saline or a placebo. Both groups were treated with insulin to control their blood sugars, and they were followed over a 2-year period of time, which is a really long time in science land. The researchers measured their blood sugars, their insulin requirements, and markers of insulin production. There were no reported acute or chronic side effects in the stem cell group compared with the control. Blood sugars and insulin production in the stem cell group were significantly better than either pre-therapy values or control patients during the follow-up period. So the treatment group, or the stem cell group, are the triangles, the black triangles on the bottom. The control group were the squares on the top. Time is along the bottom axis, and insulin requirement is along the vertical axis. And at the beginning of the study, you can see that the insulin requirement for both groups is about the same, but as time goes on, you can see that in those patients who were treated with stem cells, they required less and less and less insulin as time went on, suggesting that their pancreas actually restored insulin production all on its own. And in the control group, they required more and more insulin as time went on, which is what we would expect in patients with type 1 diabetes. That's cool, huh? Okay, so now you know why you didn't study cell biology after high school. So what does this mean for your crappy joints, right? Okay, it means that if you no longer have the healing capabilities of a 7-year-old, we now have the technology to get your body to think that it is. We use cell therapies for a long list of conditions, but let's talk about what we do the most of, and that's joint repair. Here's just some statistics. The U.S. spends more than $10 billion on hip and knee surgeries annually. The average person suffering from knee pain avoids having a total knee replacement for about 13 years. During that time, he or she spends about $35,000 on steroid injections, gel injections, medications, and physical therapy to manage their symptoms. Those interventions are to control symptoms, they don't repair the joint. Steroid injections, for example, do in fact result in short-term reductions in pain and inflammation, but actually in the long term accelerate joint degeneration. The same can be true of knee scopes or cleanup surgeries, which remove frayed or worn cartilage, but that was your cartilage, again, accelerating joint destruction. So after that 13 years of misery, our patient with severe arthritis finally decides enough is enough and schedules his or her own total knee replacement. Problem solved, right? Yeah, maybe. Knees are tough. Unfortunately, a large percentage of patients report persistent problems with their knees even after they're replaced. Some studies indicate that as few as 20% of patients report an excellent outcome with their knee replacements. Realized risks being out-of-pocket expense, the potential for surgical complications, but also the unrealized risks, which are real but harder to measure, like persistent pain and limited mobility and activity. Let's compare that to stem cell therapy. TKA is total knee replacement. Arthroplasty. Treating knee osteoarthritis with human cell and tissue products is a completely different story. Like treatment with steroids or hyaluronic acid products, stem cell tissue is delivered via a simple intra-articular injection. Knee injections aren't typically thought of as a good time, but they're not overly uncomfortable either. No sedation is required. There are no post-treatment restrictions on activity. Most patients report rather rapid improvement of pain and swelling symptoms. Like I mentioned earlier, there are no reported cases of severe adverse reactions or events, no safety concerns. And lastly, although not inexpensive, cell therapy pales in comparison to the cost of knee replacement in both realized and unrealized expenses. Some other stem cell stats on using MSCs to treat joint degeneration. Another large-scale study evaluating 1,500 patients treated with human cell and tissue products. We saw not just improvements in pain and mobility, but actual regrowth of cartilage on imaging studies as well as on surgical evaluation. That improvement continued to the 2-year mark in the vast majority of patients and up to 5 to 7 years in many others. Is this 100% successful? Does it work in 100% of people? No, of course not. No medical intervention is. But more than 90% of patients with knee osteoarthritis treated with MSCs report more than 50% improvement in joint pain. Taking that one step further, there are studies now that show that by adding platelet-rich plasma and or gel or hyaluronic acid, improve those numbers even further. So now for a lot of our joints, we're adding those two in. So in this study published in 2015, the full thickness cartilage defects of 18 monkeys, so 36 knees was evaluated. A third were treated with placebo, a third with gel, a third with mesenchymal stem cells. They were examined at 6, 12, and 24 weeks. I have to get past the gross factor, I guess, right? So on the far left, the null group, the placebo group, pictures A, B, and C at 6, 12, and 24 weeks. You can see there's really no significant change in that defect over time. In the gel group in the center, those are pictures D, E, and F. There's some thin cartilage-like repair seen at the 12 and 24-week mark, but the bone and innate cartilage underneath had very poor integrity. They actually could just peel that right off, and there was still a central deformity at the bottom at the 24-week mark. On the far right, pictures G, H, and I. In the MSC treated group by the 24-week mark, those sharp edges of the defects were evenly covered with thick reparative cartilage that was identical to the neighboring native cartilage. Cool. So what about the FDA, and why isn't this covered by my insurance? How much time do we have? Okay. So to be clear, bone marrow transplants and hematopoietic stem cell therapies, such as those used for like leukemia, those are covered by insurance. Human cell and tissue products are not covered by the FDA or are not approved by the FDA for therapies because they don't need to be. They're not considered to be drugs. They're natural biologics that fall under the FDA 361 live tissue donation guidelines. Because they're not drugs, they're not ever going to be approved as drugs. They do, however, meet the guidelines for tissue-to-tissue homologous use. Like vitamins and bioidentical hormones, natural products cannot be patented. Without an available patent, most members of Big Pharma are not willing to pay the high dollar amount to bring a product to market. Anyone know what that is? Guesses on what it costs to bring a product through phase 1, 2, and 3 clinical trials? 100 million?
Oh my gosh, 2 billion. That's what we want.
Yeah, so it's 800 million to 1.2 billion on average, some much higher than that, some as high as 3 billion. So, not profitable if there's no patent. Cell therapy has the potential to eliminate the need for an array of extremely expensive medications. If any of you know what disease-modifying drugs cost, like for RA patients, Humira, Remicade, those are high-ticket items. If cell treatments become everyday use, pharmaceutical companies stand to lose a whole lot of money. The tissue products we use come only from FDA-compliant labs. As an aside, but an important aside, beyond the processing of tissue, there is essentially zero FDA regulation of these therapies. So this is legitimately the wild, wild west. Unfortunately, any provider can say that they're doing stem cell therapy, but it's up to the consumer to know exactly what they're getting. We've taken care of multiple patients at this point who were led to believe that they were getting umbilical cord tissue when in fact they were treated with a much less expensive product called amnion. So like I mentioned earlier, the conditions we can potentially treat with MSCs are extremely diverse, sharing in common problems with regeneration, inflammation, and immune system function, degenerative joint disease, knees, hips, shoulders, back, autoimmune disease of all flavors, neurodegenerative disease, heart failure, respiratory disease, both types of diabetes, non-healing wounds like diabetic ulcers, tendon injuries, sexual dysfunction in men and in women, hair restoration, and wellness. So wellness injections, these are one-time or regular injections given to flood the system with all of the goodness that MSCs have to help the body heal and repair more quickly. You could easily argue a much more powerful weapon against influenza on an annual basis. MSCs are also used for erectile dysfunction. The overwhelming majority of men over the age of 40 will experience some degree of erectile dysfunction during the course of their lives. We have many treatment modalities for treating erectile dysfunction, MSCs being one of the most robust. We also utilize MSCs for female sexual dysfunction and urinary incontinence, hair restoration. The pictures here say it all, right? In the spirit of full disclosure, I did not treat these 3 patients that you'll see, but we are using the exact same product and protocols for hair restoration. This is an 8-month before and after. If you can't see on the left, that's a 1-month before and after, and on the right, a 2-month before and after. We can also use MSC injections locally or systemically to treat infections, non-healing wounds or injuries in areas of chronic pain and inflammation. Ready for the $1 million question? All right, that's how you came. So what does this all cost, right? It's the sticker shock. The FDA has banned the practice of culturing stem cells. Remember the doubling data? If we take one stem cell and put it in a petri dish in an umbilical cord, after 1 month we have 1 billion cells that we can use. That's illegal to do in the United States. So every single cell that we use comes from its original source. Selecting, harvesting, processing stem cells is, and it should be, a long and very arduous process for safety purposes, right? Those 2 factors, until things change from a regulatory standpoint, are going to continue to drive the price of cell therapy high. But what's more important than your health, right? All right. So where does this all fit in? I really believe that cell therapies represent the new frontier of medicine and wellness. I think in the next 10 years that this therapy is going to be much more mainstream for the treatment of degenerative disease, inflammatory conditions, autoimmune disease. In closing, we've had some really large quantum leaps forward in medicine and the discovery of vaccinations, which allowed for the prevention of incurable disease. Then, love them or hate them, the discovery of antibiotics, which have saved countless lives. Now we're seeing the back edge of that sword with overuse and resistance, but there's no denying the fact that they have saved countless lives. Surgery, anesthesia have improved pain and suffering tremendously. I believe the next frontier of science and regenerative medicine is going to be cell therapy. And I appreciate you all coming here tonight to learn more about it. Thank you.
Thank you.